All right. Hello, everyone. This is Jim Lloyd here at Rutgers University and JAX, and welcome to another of our Integrating Special Populations Core webinars for the New Jersey Alliance for Clinical and Translational Science. Today, we are excited to have Dr. Katie Devine from the Cancer Institute of New Jersey here to present on some research about using technology to connect with adolescent and young adult cancer survivors. If you have any questions in the course of this presentation, you can unmute and ask them. But if you don't mind waiting till the end, you can place them in the chat and we will pull them up then. It's a really fascinating topic. I can't wait to hear more. So without further ado, here is CHSR's own Natalia Herman to introduce our speaker.
Thank you, Jim. My name is Natalia Herman. I am a co-coordinator for the NJX Special Populations Core. It is my distinct pleasure to introduce Dr. Katie Devine as our final presenter in our 2022 seminar series. Katie Devine is an associate professor of pediatrics and the section chief of pediatric population science, outcomes, and disparities research in the Division of Pediatric Hematology Oncology. She received her BS in Human Development from Cornell University and earned her PhD in clinical psychology from the University of Georgia and completed a postdoctoral fellowship in pediatric psychology at Loyola University in Chicago. She earned her MPH from the University of Rochester Medical Center and is a licensed psychologist. Her research focuses on the psychosocial aspects of pediatric, adolescent, and young adult cancer survivorship, including patient and family adaptation to illness, adherence to medical recommendations, and survivorship care and health promotion for survivors. Much of her work focuses on digital health interventions for adolescent and young adult survivors. Katie, it's all you.
Thank you, Natalia, for that lovely introduction, and thank you for having me here today. I'm delighted to be able to present my work. I have no conflicts of interest to disclose. So today I'm going to really briefly overview why we are using technology to reach adolescents and young adults. I'll give the background of cancer in children, adolescents, and young adults, and the need for behavioral and lifestyle interventions for this population. And then I'll talk mostly about one of my research applications in managing your health study for our young adult cancer survivors, as well as I'll touch briefly on our Fit Survivor intervention. That's an exercise-focused intervention for adolescent and young adult survivors. So this is probably preaching to the choir here in terms of why are researchers and health interventionists interested in technology? And so in the last 20 years, you've seen the rise of mobile health technology, or mHealth, which really can be called by a number of names: e-health, digital health, all of these things, and incorporates any use of technology in the promotion, prevention, treatment, or maintenance of health and healthcare. So these are things like wearable devices, telehealth, telemedicine, texting, short message service, mobile apps, virtual reality, and serious games. So it's a wide range of applications of technology. And why are we using this to reach folks? As you can see, these are the data from the Pew Research Center that show that pretty much everyone in the United States owns a smartphone by now. And when you look by age, this is the percent of US adults who say they own a cell phone or a smartphone. You can see that number approaches 100% overall for adults. When you actually look by young adults and teens, it's 100% of young adults in the surveyed owned a cell phone and 96% owned a smartphone. For teens, it was 95% smartphone ownership. So really, these are in everyone's everyday life. And some of the data suggests, particularly among adolescents, that over half of adolescents actually say that they're online almost constantly on their phones. And anyone who has an adolescent probably is well aware of that as well. When you think about what they're doing on their phones, accessing the internet is one of the most commonly reported things. Social media is another very common application. You can see here on the left side of the screen, this is social media used by adults, so 18 and over, and they separate the young adult group out. And you can see across platforms, young adults use social media at much greater rates than older adults. When you look at teenagers, this data is a few years older. But again, the top three, the majority of teenagers use three social media platforms. And most of the time when people say how often they use it, it's at least once a day. So again, ubiquitous use of mobile phones and social media in daily life. Now, what about the promise of mHealth? So why do researchers want to get our interventions into mobile delivery? So a huge promise is the increased reach. So because so many people are on their phones, this is a way of reaching people in their daily lives wherever they are. They don't have to come to our cancer center. They don't have to come to our medical center to have these interventions. They also can be lower cost. There's often an increased upfront cost to build an intervention, but over time it's less costly than in-person intensive interventions. It reduces the geographic access barrier, which also has the potential to reduce disparities in access to healthcare services. And the digital divide in terms of disparities tends to be a little bit lower than the access divide in coming to healthcare centers and accessing quality healthcare. It also gives us the opportunities to use wearables and other objective monitoring devices to get real-time feedback to participants, and the opportunity for just-in-time interventions that happen where people need them when they need them. And as you can see, there's a growing market for these types of apps. So this is just a snapshot of industry growth of apps over the last 10 years or so and projected growth. You can see fitness and workout and exercise apps are one of the top market shares, but over time actually growing in other areas, particularly in disease management and nutrition and diet as well. But are these apps effective? So that's the big question. And among adolescents and young adults, there are some promising data suggesting that they can have impacts across things like physical activity, obesity and weight management, self-management of chronic disease, adherence to medications. But the data are generally not really strong yet in these areas. And one of the major issues is all of this growth of apps and technology, but will people use it? And so there's data to suggest, a minority of people actually open an app or open an app only once after downloading it, and then really do not sustain their use over time and abandon or quit the apps relatively quickly. And one of the things for researchers that's really important to think about as you're planning a mobile intervention is, do you build your own or do you use one of these commercially available apps that are already out there and perhaps even well invested in terms of some of the large market shares of things like Fitbit and Nike and those very popular apps. And so thinking about whether you build your own, think about whether you have a unique need that is not satisfied by the market already. The cost is very costly to build your own app that will compete with the commercially available apps in terms of the, staying on top of the technology, the sustainability of building your own app. So once you build something, you have to keep it up to date or it won't be able to stay in the app store and stay over time because of constantly changing technology. And thinking about competition and whether, there are the competitors apps out there would really be more preferred by your population. And so we have a little meme here that, I think as a researcher sometimes and others, it's like, maybe we need a mobile app to get people to use our mobile app already. So let me talk now about how do we apply some of what we know about mobile health to our unique population of childhood cancer survivors. So I'll give you a really brief overview of cancer in children, adolescents, and young adults. So there is about a little over 11,000 new cases for children under the age of 15 and close to 90,000 new cases for adolescents and young adults in the ages of 15 to 39, which is the definition of the National Cancer Institute. Most cases are random and sporadic, though we're learning more and more about genetic underpinnings every day. And when I talk about our adolescent and young adult survivors of pediatric cancer, there's really two groups that we refer to. And so those are those who are now adolescent and young adults, but were diagnosed as children sometime before the age of 15, and those who are diagnosed as adolescents and young adults in the ages of 15 to 39. And one of the great stories of modern medicine is actually the improvement in childhood cancer treatment over the last 50 years, that really we're seeing a rapid growth in survivors and a improvement in survival rates. So now there are estimated, actually this number is slightly outdated, it's estimated now over about 500,000 childhood cancer survivors in the US, and about 1 in every 530 young adults is a cancer survivor. This is a busy slide, but just the point of showing you here is that the types of cancer that kids, adolescents, and young adults get is different than the types of cancer that adults over 40 get. And so this graph just shows from the left to the right how the types of cancers change dramatically over this age range, to be very different in childhood than it is in adulthood. As I mentioned, the survival rates are up, which is fantastic. You can see a particularly dramatic increase for our pediatric patients under the age of 15 in the last 50 years, and a less steady improvement in our young adults. And that's part of the reason that they're actually identified as a particularly vulnerable group by the National Cancer Institute, and there's more research going on for this age range. This again just shows the survival rates, that even though overall we have shown dramatic improvements, it really does depend on the type of cancer. And so, we have some rates that are over 97%, which is fantastic. And then we have other areas where we're not doing quite as well and need to see improvement in our survival rates. So what about our young adults after cancer? So thinking about our survivors, many of our childhood cancer survivors are at risk for late health effects, which is a health problem that can occur months or even years after treatment has ended. What we know over the last several decades, there's been a ton of research looking at what types of late effects childhood cancer survivors are at risk for, and really any organ system can be affected. The majority of survivors will experience at least one late health effect. Data suggests that by survey report, about 62% experience a chronic health condition in adulthood. And if you actually bring patients back and do a thorough medical exam, you'll find actually about 95% will have at least one chronic health condition related to their cancer treatment. And the risk of late effects is due to the cancer itself, but really due to a lot of the treatments that they receive, and as well as patient-related factors, such as the gender, when a patient is diagnosed and treated, and lifestyle factors later on in life. So why do we need health promotion interventions for this group? So one of the things that has been shown in study after study is that our young adult survivors, despite being a vulnerable group, they actually do not behave in dramatically different than their peers who do not have a history of cancer. So they generally engage in risky behaviors and healthy health promoting behaviors at the same rate as their siblings or peers. Yet they're actually at risk for a number of different health effects. So we would really prefer to see them engaging in less risky behaviors and engaging in more healthy behaviors. They're also a vulnerable group due to the unique needs of this age group, thinking about our adolescents and young adults. And most of our interventions to date have focused either on adult survivors and sort of trying to develop it downward towards our adolescent and young adults, or our child survivors and trying to develop it upward. And so you need to really think, when you're developing interventions for this group, how can I tailor these interventions to meet their unique needs? And what are those unique needs? So adolescents and young adults here, I'm thinking, again, that 15 to 39 age range is a very different developmental period in life. And really it's a time where as adolescents are going into adulthood and young adulthood, it's a time of dramatic change in almost every life domain. So thinking about physical changes, cognitive changes, social changes, emotional changes. Besides infancy, this is another period of development where there's so much happening. And for AYA survivors, when cancer diagnosis comes on top of that, it really can impact how they're developing and their developmental trajectory. And so here is an image showing just how cancer can disrupt all of these life domains, from body image, emotions, trust in their health, their plans for career, education, finances, being really challenged by a cancer diagnosis, and all the medical costs that they have to do, thinking about their fertility, future planning, peer relationships, and their health behaviors. And so really this, in the last, I would say 20 years or so, this is adolescents and young adults have gained a lot of attention because there's so much happening for them, and we really need better interventions that help and have this context of what they're going through. So as I mentioned, it's really critical for our survivors to have long-term follow-up care, to monitor for these late effects, and also surveil for secondary cancers that they're at risk for, or even recurrence of the primary cancer. So for the Children's Oncology Group is one of the national and international organizations that really focuses on the clinical trials for childhood cancer and looking at long-term guidelines. And so that group, as well as some other international groups, have made recommendations based on what we know about risk exposures of therapy for lifelong risk-based follow-up care. So this care would be tailored to an individual's exposures as well as their own personal characteristics. What we know from talking with our young survivors is that while the majority of them receive ongoing medical care in survivorship, less than 20% of them receive this type of risk-based, personalized follow-up care that is really recommended. So it's a huge gap in getting people to care. One of the major areas of gap is actually in that transition from parent-guided to self-guided adult care. So focusing on our young adults in their late teens, early 20s, as they transition out of the traditional pediatric healthcare setting to an adult healthcare setting. Many survivors can actually continue to see a specialized survivorship care center like we have at the Rutgers Cancer Institute of New Jersey. But even if they do not change health providers for their survivorship care, they really do need to take on that self-management of care and transition from their parent leading their care to themselves. And so one of the goals of our research has been to improve the idea of transition readiness, or giving people the skills, the knowledge, and empowerment to take on their own healthcare and feel ready to independently manage their care. So our work has focused on this age range of 18 to 25 as the time of transition. So our managing your health intervention has been guided by theories related to transition readiness and self-management. And this is sort of an overview of the series of steps we've taken to engage our population and create a intervention that will be useful to them. We started with a formative qualitative study looking at barriers to obtaining care. Then we designed a small proposal for our new study about how we might intervene and the types of content we would have. We got feedback from survivors, parents, and healthcare providers. We ran a single-arm feasibility study of the intervention, got more feedback on the content, the delivery, the mode, and then we ran a small randomized study looking at the feasibility. So what is this intervention? So one of the major barriers to our young adults obtaining survivorship care is not knowing much about their care, a lack of knowledge, a lack of support in navigating the healthcare system, feeling a bit on their own, and also feeling that they are different from their peers. And one of the constant themes we heard in our early work was that none of their friends have to do this. Why do I have to do it? And you see that in young adults broadly without health conditions, that often they sort of drop out of the healthcare system for several years in their early 20s because they're healthy and don't need to seek care. So our intervention wanted to try to tackle some of those barriers. So we created an online self-management educational intervention. And to address the big piece about the lack of social support and feeling isolated and different from their peers, we added a peer mentoring component where we decided to match people one-to-one with a peer mentor who does manage their health very well and could offer support and guidance tailored to the individual's needs. It really capitalizes on some theories regarding how experiential similarity can really enhance people's ability to offer support and receive support when they believe someone else has experienced something very similar. They take that support and that advice more seriously. So our online educational tools, you can see some screenshots here. These are the later screenshots. I should have showed you some of the earlier ones. We actually originally, in the small feasibility study, we used Rutgers Canvas website to create our intervention to get feedback on the content. And it was very plain. And that was one of the, loud and clear messages, that they needed to be more engaging. And so here's what we came up with. Lots of pictures. You can see here in these modules that each module would show a progress bar, so they knew how much they had to get through. And then here's just an example of what, on the right side, you can see examples of some of the content. And so the content really focused on addressing knowledge, understanding their survivorship care plan, managing their healthcare, and that really looked at things like navigating the complex adult healthcare system, navigating insurance, getting family and friend support, dealing with the emotions about health. Often people report anxiety about their health because there is uncertainty in their future and what health effects they may have, and how they handle that. And then addressing staying healthy, and that module addressed health behaviors. As I mentioned, they do not engage in as many health promoting behaviors as we'd like them to. So that is where this module came in. So let me tell you a little bit about the feasibility trial that we ran. With a 1-to-1 randomized design, they were randomized either to the intervention or usual care, which for most of our survivors is not much. We were focused on evaluating the feasibility and acceptability, because this is a bit of a different approach. Having them matched up with a peer mentor is a sort of novel in a way of offering support. Other interventions have gone with sort of group interventions or more like online forums where people are open to interact, but it does require, I think, a bit of a push to get people to engage in those types of forums. So we went with the 1-to-1, purposely feeling that it might be more comfortable for people. And this is what came up in our initial usability data, our initial qualitative data too, that they wanted to connect to someone, but they weren't really going online and doing support groups or support forums. We also purposely recruited through the New Jersey State Cancer Registry. The registry, every time there is a case of cancer diagnosed in the state of New Jersey, they report it to the registry. And so we wanted to try to reach survivors who are not necessarily connected to our local long-term survivorship clinic, our light clinic here. And this is purposeful because I think these are the survivors really in need of pulling back into the healthcare system. And so here's the eligibility criteria again for our survivors. We were looking at 18 to 25, and our mentors, we were looking for slightly older participants to really kind of let them have a little more experience than their peer and offer a little bit more. Our outcome measures really focused on feasibility. So things like would people sign up for this? Would they stay in the study? Would they engage with the peer mentor and the online modules? Were they satisfied with it? Did they feel like it was effective and useful for them? And then our behavioral outcome was that idea of transition readiness. So do they have the skills and the knowledge to independently manage their care? And so we used 2 different measures of that. So our recruitment and retention. So through the state registry, it's a really interesting resource to use. So when you think about our young adult survivors, this was a big question for us, is could we actually get in touch with these survivors? So they're registered in the registry when they are diagnosed, which may be many years prior to when we're trying to reach out to them. And when they're registered in the registry, it's their parents' address. It's their home address when they were a child, when they were diagnosed. So most likely for our young adults who are very mobile, tend to go off to school and different, move for jobs and all those things, we weren't sure if we would be able to find them. So we started with a pool of about 336 survivors. The registry was able to contact about 1/3 of them. And that was through mailings and phone. And I will say anecdotally, I don't have the exact number, but many of these contacts were actually with a parent and not the young adult. So we were relying on talking to the parent to get that information then to the young adult. Of those 107, we were able to screen 81 of them, which is about 75%. and we enrolled 50 of those 81. Now, most of those people actually screened ineligible because you had to have a lower level of self-management to get into the study. So you can see we had a great enrollment rate of those who were eligible. But when you look at the overall pool, it takes a relatively large sample to get a large pool to get a reasonable sample. Of everyone who enrolled, everybody did complete the baseline. We had equal randomization to the intervention and usual care. And we had 22 out of 25 complete the intervention, or 88%. I will say most of those who dropped out right after being randomized or after the first session where they decided they just really didn't have time to do it. And we had a good retention rate at our second survey post-intervention. Here is sample characteristics. So you can see these do really reflect our catchment area and the state of New Jersey and our age range. So you can see most people were students and or working. So let's talk about engagement. So could we get people to do the intervention? We were really pleased with these results. So as I mentioned, 22 out of 25 completed all of their calls with their mentors. So once people initiated the intervention, they seemed to really follow through with it. It was that first, we had the few dropouts in that first hump of getting into the intervention, but once they were in, they really did. The average call duration was about 16 to 20 minutes, depending on the call. And the responses, we asked people at the end, so was the duration of each call, pretty good? And was the frequency once a week with the plan over 6 weeks, was that satisfactory to you? And so most people reported that duration and spacing were right on, rather than, if anything, a little too short on the duration. Did they do the online module? So one of the biggest problems with online interventions is that people never go back and actually, do what they're supposed to do. So we had set ourselves a goal of having 75% completion rate, and you can see we far exceeded it. We had, for the first few modules, we had everyone complete, and we had a little bit of a drop off by the last couple of modules. One thing that was interesting that we were looking at is how they were completing it. So were they on their phone or were they on a desktop? And we found actually it was split almost 50-50. Some people were on a laptop, desktop, or a little less than half on their phone. And did they like it? So by far, the peer mentor was rated highest in terms of their satisfaction with the program. The modules were rated, again, most people were mostly or very satisfied, and overall matched their, again, mostly or very satisfied. So how do I summarize the study? So we had set ourselves thresholds for feasibility related to all the markers you can see here: enrollment, retention, completion or engagement with the intervention, satisfaction, and a rating of acceptability. And so we were really pleased that our results exceeded our thresholds on every marker. So we really do feel like this intervention is feasible to deliver and acceptable to our participants. Our results, looking at our outcomes on transition readiness, we saw 2 of the 3 markers demonstrated improvement favoring the intervention condition to control. So again, this was, while we weren't powered to look at our outcomes as a primary efficacy trial, it was still heartening to see that the trend was in the direction we were expecting. And what did we learn? So one of the things, as I mentioned, we were interested, did people complete this on a laptop or a phone? And it was about half and half. But what they told us at the end is they really wanted to complete it on their phone, but it just wasn't as user-friendly as they would like. Even though the website was mobile responsive, it still just didn't feel like it was built for the phone. So they wanted to do that. And the second feedback was they really loved the interactive components. So some of the interactive components were animated videos where they, demonstrated a concept, and our self quizzes where they had to, apply the concept we were teaching them to their own personal life or personal situation. And so they wanted to see more of those in the modules. So what did we do? We decided we needed to build this Managing Your Health 2.0. And so we obtained a small business innovation research grant, partnering with our Radiant Digital Health, which is our technology partner. And we were able to get money for a phase 1 grant, which allowed us to build a prototype of an app-based intervention. So to do that, we had 4 objectives. One of the things when you're building mobile interventions that we think is really critical and has demonstrated in the literature to be really critical is engaging your stakeholders, your key stakeholders, your end users early in the process. So our goal with this new grant was really to engage our stakeholders even more than what we've done already. We had them involved all the way so far, and to try to design an app-based prototype to do what the original intervention was doing, and then to evaluate the usability and feasibility of the app itself. So our formative work involved workshops with key informants. You can see here most of our key informants were target users, but we also engaged other people who are really highly invested in helping young adult survivors. So we had parent and patient advocates. We had representative from a nonprofit organization who does a lot of advocacy work. We had our oncologists, and we had primary care providers. And the activities that they did during these workshops were first identifying more openly what are the key barriers that the app should address, and then actually looking at some prototype screenshots of the key features that we'd like to develop more and getting feedback on those wireframes. So what did we find with the barriers? The good news was that the barriers matched our current content. So because we had done a lot of formative work to get to where we were, we feel really confident that here are the major barriers facing our childhood cancer survivors. And these are the ones, I won't read them all now because we've already talked about them, but one that kind of came up maybe even more so than prior with this last one here, and thinking about the lack of primary care providers who have training to work with childhood cancer survivors and manage their survivorship care. While there are many people do try to go to a specialized childhood cancer survivor clinic, they're really only available in major cities where there are comprehensive cancer centers like in New Brunswick, or in other major cities like Atlanta and New York. And really, if you live too far from them, you're going to rely on your primary care provider to do this type of care. Some of the recommendations they had for designing the app is really to keep it simple. People were really very clear that they want things to be easy to interact with, keep a checklist of tasks that they can complete, don't use medical jargon, try to really make it easy to understand. And they wanted tools to share this information with their primary care providers in a way that they can just easily give this information to others who might need it. We asked them to rate different features and wireframes as something they would, they must have it. It must be in the app to they'd like it if there's room, or, you don't really need it. And what we found is some of the must-have features were access to their survivorship care plan, tools to share information with their primary care provider, and tools to educate a primary care provider. They wanted things that they wanted, if we could do it, saving topics of interest, choosing an insurance plan, strategies for managing stress. And then we had mixed results on something that we felt was relatively surprising for our young adults, is that they really weren't sure that they wanted gamification elements like badges earned for completing tasks in the app, or points related to various things that you have to do. Some people liked it and felt like it would motivate them to keep going through. Other people felt like this topic area was such a serious topic, their health is really important, and gamification might belittle it a bit and make it sound less important than it is. So that was a mixed review that we weren't expecting. So again, it kind of highlights how it's important to engage your users early on. So how do we take this data and translate it into the app? So one of the things we decided based on these feedback is that we would onboard users with a brief questionnaire to help them tailor the content to what they need. So if they really wanted stuff on insurance, we would make sure that would be highlighted for them. If they really wanted something on physical activity, that would be something that we would highlight, versus, they're doing fine on their, sleep, so they don't need something related to that. We also wanted to allow them to save content they felt was important, skip content that they feel like wasn't as relevant. Our ultimate goal is to connect to their personal health records so they can review their own survivorship care plan. within the app. We also really want to teach some strategies to help our young adults effectively share information with their primary care providers. So not just giving them a tool to send the information, but how do they engage their primary care survivor in a discussion about what they need, and also resources that they can share directly with their primary care. Here are some screenshots of the app itself. You can see here all the way on the left, oops, so sorry. All the way on the left is the onboarding questionnaire. The second panel here is the dashboard showing the different modules as well as other kind of quick tasks we want them to access. The third is just an example of what the new modules are. You saw the old example. This is the new example of the introduction to a new module. Again, more content. You can see that the content is broken up by more visuals, trying to make it interesting and readable. And then all the way on the right, we have the interaction with the mentor and how people would be able to select their mentor and communicate directly from the app. I failed to mention earlier that in our prior studies, we had to use different systems for them to interact. They had one app to interact with their mentor, and then they had the online system, which was different. And that was a little confusing for people, even though they're very adept at navigating online systems, but they wanted it all in one place. So what is our progress so far? So we created that prototype that you can see. It is a usable working prototype. We just completed last week usability testing with 25 adolescent and young adult survivors. During that, we asked them to complete certain tasks and observe them as they were completing the task to see where they went wrong or things that weren't quite working. We identified a number of tweaks to the interface that we can make that either were bugs that need to be fixed, or were just things that didn't quite make sense to our users, and we want to make it a little bit more user friendly. We've also identified feature upgrades that we really want to do, one of which is that the integration to electronic health records. And so our current goal is we're actually presenting to the National Cancer Institute tomorrow to review our findings, and they're going to apply for additional phase 2 funding to really develop all of these features and then test it in a larger study. So I want to thank this team. As you imagine, team science is so critical for this. And so we have our Radiant Creative Group, which is our digital partners, and then a number of co-investigators here at Rutgers Cancer Institute, as well as at other hospitals and the Cancer Registry, and our funding. And I am going to just pause to give you a very brief overview of our other app that we won't have enough time to go through today, but I just want to share a separate example and then I'll take questions. So our second app is a Fit Survivor exercise intervention, which was actually part of a group-based intervention that we did in person pre-pandemic, as well as this app that we developed at the time. And I'm just going to breeze through these because I just want to show you the evolution of this app. Again, we use interviews and focus groups early on to get a picture, and we purposely actually made our wireframes at that time much more low key in terms of they looked more draft focused, because we wanted to get a lot of input to change things early on. Here are just some screenshots of how the app finished up in terms of some of the things we had. We had paired it with a Fitbit, so they got feedback on their actual objective, wearable activity tracker, as well as had workouts that were designed for our group that they did in person and then they could do on their own in the app. This is a little busy, but the idea is that when we were designing this app, we were looking at behavior change techniques. How do we implement them as app features and as in-person features? Because we had a hybrid model for this project. So I'm just going to breeze through these, but they basically we were trying to hit a lot of the major areas of giving them actual instruction, goal setting, support, and overcoming barriers. The program was for our ages 13 to 25, and we had 8 weeks of these group sessions as well as using the app. This was done in a small randomized trial with our outcomes looking at strength and fitness as our primary health outcomes. And we enrolled, this was a small feasibility study as well. So we enrolled 49 participants. And you can see here our feasibility rates. Again, our enrollment in this intervention, but like much health exercise interventions, was not quite as high in terms of enrolled of eligible, 64%, but still it's on par with other studies. Did have a fair amount of dropout, but people who stayed in the study attended about 6 out of 8 sessions. In terms of their app engagement, we found variable engagement, as you would imagine. So you can see people were supposed to complete about 1 to 2 workouts a week. They did not. And they earned points, and we had a number of achievements and things that they did earn, but as you can just see, the ranges here is dramatically different across participants. But overall, they were satisfied with their participation. Here are just a few quotes about the type of feedback we got, that people really felt like it helped them be motivated. They learned a lot and felt both personal benefits as well as enjoying the social engagement with other young adults, adolescents and young adults. So we did conclude for this study, we just published it in last year in Pediatric Blood and Cancer, that Fit Survivor was feasible and demonstrated some promising results, but there are a lot of barriers to doing a large efficacy trial with that hybrid model. And so in-person attendance for our adolescents and young adults is almost impossible to get a large enough group who's available at the same time in the same location. And so we are actually currently thinking about reworking this to be a Zoom-based intervention where we can engage people either individually or in a group over a virtual platform. And in terms of the app development, one of the things that I mentioned earlier in the talk is that actually it's really hard to compete with fitness apps. And so going forward, our goal with this would be just to capitalize on commercially available apps instead of maintaining our own app, because it's difficult to do. And there are lots of great apps available already in the marketplace. Just a few key takeaways that I'll end on today. One of the things that's really important when you're designing these types of apps and thinking about engaging people is, how do you define engagement? So a lot of times we think about engagement just by, how often do they use it? But we also want to think like, what is a meaningful amount of use that is needed to translate to your effective behavior change? And I think that's something in the literature that's really coming about now, and thinking about different things that promote sustained use, such as gamification or prompts. Tailoring information to the individual seems to be helpful. And so I think for your own studies, thinking about, what do you think it will really take? What kind of engagement do you need to translate to meaningful behavior change? There's also really great new work coming out with adaptive designs and thinking about how people respond, and then changing your intervention based on people's responsive. And so that's something I think to keep in mind for future planning as well. I just want to acknowledge again the team related to our Fit Survivor work and our funding for that. And finally, I'm happy to take any questions. Either feel free to unmute yourself, or I will also now look at the chat to see if anything came up.
Hi, Katie. It's Ned.
Hey, Ned.
Great talk and really interesting. As you may remember, I remember the FIT one.
Yes.
But your latest endeavor is really interesting. I had a question, is that with the back and forth between the patients and the providers, is this turning out, and you may have touched on it, but is this turning out to be educational and helpful for the providers? I mean, one could envision with that kind of back and forth in interaction that providers could say, gee, I didn't realize that was important to them. Or, boy, they're really interested in X, and could that affect the provider's interactions with the patients?
Yeah, that's a fantastic question. I think so. I think we haven't done enough in our testing yet where they're really using it in their real life with providers. But I think it's a really important point for us to consider how to measure going forward, that if we can look at that, because one of the issues we hear time and again is that our primary care providers are really hesitant to work with our survivors because, they maybe in their practice, they've had 1 or 2, their entire practice, where they've had to work with these survivors, and they are at, risk for serious health effects that they don't quite know. They don't have the training on how to monitor. And so we do find that many of them are hesitant to engage. And so I hope that this tool could be helpful. That's one of the reasons we went with working with our survivors versus doing more of a provider education, was because it would take, we can teach our survivors to be advocates, but it would take a lot of providers to teach, for them to make an impact on how many of them would actually have survivors in their care, or childhood cancer survivors. Many of them have adult cancer survivors, but yeah, so I think that's a great point, though. I think we'll have to figure out if there's a way for us to then measure whether this changes their interactions with their providers going forward.
Great talk again.
Thank you.
Katie, I see there's one question in the chat about having the app translated into different languages.
Mm-hmm. Yeah, that's a great question also. I think that is ideally that's where we would go. The Managing Your Health app right now is only in English, but when we apply for funding, we're going to be applying for a large grant this fall. And I hope that we'll be able to translate it at least to Spanish as a second language. And then, if this can take off, it would be great to see this in multiple languages in the future.
Hi, Katie, this is Jim. I saw earlier you had mentioned the kind of social engagement element. And I was wondering, like, when you started off the presentation looking at kind of young adults and adolescents versus the older adult population, I thought about that kind of connection with other cancer patients in the community, peers. And then there was that quote, "None of my friends have to do this, why do I?" I was wondering if you could just expand a little bit on kind of what your research found about how that population views the importance of social engagement, and if you all have any plans to look more into that or include more in your apps.
Yeah, I think that's great. It's one of those things that, especially for adolescents and young adults, it's a very commonly reported unmet need, that they don't have engagement with other survivors. They typically do not know someone in their own personal network who is another survivor, but would be connected through a hospital or something like that. But what we find is the uptake of support groups is not as, it doesn't match what they're saying. So a lot of our young adults report this unmet need, but we don't get a lot of uptake in online support groups, online discussion forums. If you just because you build something, it really takes a lot of planful prompting by a moderator to encourage engagement. So for our Managing Your Health study, that's actually why we went with the one-to-one matching. And they did really complete all of their calls. If they participated in the intervention, they really completed all their calls. And that's what they said afterwards. Like, that was really helpful talking to someone else. One thing we also noted, I didn't present this data earlier, but we looked at the time when people went on to do their the module that they were supposed to complete. So each week they had to talk with their mentor, and they were supposed to talk about the topic of the module that day. And what we see is it's somewhere over 75% of people logged into the module the same day of their call, right? So the peer offers support, but they also offer this accountability. Like, they're like, oh, someone's going to be talking to me about this, so I better do what I'm supposed to do. And so I think it was a really nice gauge of a way to engage them, not only in applying the concepts during their discussions with their mentor, but just engage them in the intervention. That I don't know that we would have seen that completion rate with the modules if we hadn't had that human support person checking in with them and engaging with them. Yeah, really going forward, we're also toying with the idea of for the fitness intervention, whether there's a way to capitalize on that peer support too, and whether like matching them one-to-one with someone or doing more of a group-based intervention would be helpful, because they really do seem to like that piece of it, and just doing it well is the tricky part.
Thanks, that was really interesting.
Katie, I just have a quick question. Did you talk to the mentors afterwards to get their input on how things went and collect any metrics from them on that side?
Yes, great question. We did. And what we heard from them is that they really enjoyed participating in it. And actually, as I think someone's question earlier was like, oh, why people do it. And they said actually giving back was one of the things they really liked, connecting with others and being able to give back to another survivor. That was a theme that came through. We also did look at some quantitative data, looking at their own like self-management and their confidence in managing their own healthcare. And they were already very high. That's why we picked them, right? So there's somewhat of a ceiling effect on that. But we did even see an uptick in their own, confidence, that like by talking to someone else, they felt more confident in doing it themselves. And so I think there were benefits for the mentors as well.
That's great. Thank you. Looks like we've got about 5 minutes left in our time slot. So find out if there's any other questions and go from there.
Katie, one more quick question. In the FIT program,
Mhm.
do you find that those that you have engaged in that keep going? I mean, or is there a sort of a finite, and well, done that, now I'm going to move on to something else in the gym or something?
Yeah, that's a good question. So we found a small number of people keep going. I think much like in-person exercise interventions broadly, you sort of have a small group that becomes an adopter, and it becomes more of their lifestyle. And then you have a number of people who really need the structure of the intervention program to keep going. And I think for us, one thing that we learned too in terms of our age group is for that intervention, we did 13 to 25. And for the adolescents, there's a bit of a difficulty in sustaining some of these behaviors because they don't really have as much control over their lifestyle or where they go. And, they rely on a parent to go to exercise or to sign them up for a sport or something. So I think that even going further, we need to tweak things and maybe include parents for our teenagers, and for our young adults, just helping them really get into that habit. We did find broadly that our men were much more interested in some of the gym-based activities versus a lot of our workouts were purposely designed to be done at home. So you didn't have to go to a gym, but we saw the men, more men than women, really engaged with more weightlifting and wanted to pursue that route. So I think, again, the next phase really has to try to tailor it to what most interests the person and what they have access to. So we can try to capitalize on their motivation and get them in a more lifestyle modification than just the structure of the program.
Thanks.
I don't see any more questions. We're just about at time. I'll echo one comment from the chat, which says impressive and impactful work. It certainly does look that way. Thank you for giving your time. Professor Devine, if you have any more comments you want to make, otherwise just, thank you so much. And thank you to our audience.
Thank you very much. And feel free to reach out. My email's there if anyone wants to follow up or touch base about potential collaborations.